I'm Phil Prazio from the University of Pennsylvania. I'm super excited to start this segment to bring you a little in-depth information about some of the publications going on in the Journal of Urology and other publications every month. There are 3 phenomenal articles on upper tract urothelial cancer. It coincides perfectly with the release of the AUA's first ever upper tract urothelial cancer guidelines. And with me today, I have 2 exceptional guests and friends who are experts in upper tract urothelial cancer to talk about the disease, these papers, and the guidelines and how they all play into practice. So first we have Sarah Sutka from Seattle and John Coleman from New York. I'll ask Sarah, please introduce yourself first for the audience.
Thanks so much, Phil. So my name is Sarah Sutka. I'm an associate professor of urology at the University of Washington and the Fred Hutchinson Cancer Center, and absolutely delighted to be here today. It was a true privilege to serve on the guidelines committee for the upcoming upper tract guidelines, and really excited to discuss these articles with you.
Jonathan Coleman. I'm a urologist at Memorial Sloan Kettering and specializing in upper tract urothelial cancer and kidney cancer, prostate cancer as well to some degree. The guidelines that we put together this year was it was a real effort. I got to say, it was very challenging to do that. What a great team we had. I think they were all stars, everyone who worked together. We did this through the COVID pandemic. We started it and finished it, and we did it all virtually and online and delivered it in time, which was great. So terrific team effort. And I think it's going to make a real difference for how we manage and think about patients with upper tract urothelial carcinoma and bring a standardized approach to their care.
Yeah, and as we all know, upper tract urothelial cancer, relatively rare disease, 8,000 to 9,000 people per year in the United States, can be really challenging to diagnose and treat. And so we're going to start with the first article today. This is a urine-based DNA methylation marker test to detect upper tract urothelial carcinoma, a prospective cohort study from the group at USC. Sarah, I'll ask you just kind of quickly, what were your initial takes on, a urine-based test? And is this something important we need for upper tract urothelial cancer?
Well, I think, so first of all, the answer, do we need this, is we absolutely need better diagnostic testing. One of the biggest challenges with upper tract urothelial carcinoma is that it's actually extremely hard sometimes to detect. Our imaging, we'll talk a little bit about sort of the challenges of imaging it and characterizing the tumor based on radiographic findings. But the other issue is really we are limited by the size of the ureter and our ability with our instrumentation that's available to stage it and even appropriately identify the grading. And one of the things that we'll sort of highlight in the upcoming guidelines is a new risk stratification framework that I think really helps sort of break down how we characterize this tumor. But the tricky bit is actually getting the data in order to appropriately characterize the tumor. So having a diagnostic urine-based test that's a little bit less invasive, of course, than some of the traditional interventions that we have to use to diagnose upper tract urothelial carcinoma, it's really critical. And this was an interesting study. Moving beyond sort of the classic biomarker that we all rely on very heavily, which is urine cytology. So obviously urine cytology at this point is the predominant sort of urine-based biomarker test that we use to diagnose bladder cancer and upper tract urothelial carcinoma. The specificity of it is acceptable, right? It's usually pretty high. It's somewhere in the 90s if we look at the data that's out there. But the problem is the sensitivity, and it's not very good at all in detecting low-grade urothelial carcinoma. So the problem is that in the absence of any other additional testing, we have basically a critical need for urine-based biomarker testing. So this is the panel that the authors looked at here was something they called the bladder care test. It's a urine-based epigenetic test, and it's specifically looking at a panel of 3 urothelial specific methylation biomarkers. And this was basically a very nice validation study in which they looked at 50 patients who had upper tract urothelial carcinoma in the absence of bladder cancer, and they were compared to controls and demonstrated a substantial performance with respect to accuracy, sensitivity, and specificity, as well as the positive and negative predictive value. So just to sort of summarize, and we can kind of dive into it a little bit more, the sensitivity of this test was 96%, which vastly outcompetes. It wasn't a direct comparison to cytology, but vastly outcompetes what we have available to us right now as cytology. And then the specificity was 88%, and the positive predictive value, 89, negative predictive value, 96%. So really pretty exceptional performance in comparison to what we have to date.
Yeah, I think that was most intriguing to me is the performance and sensitivity and really being able to rule out cancer. And obviously, this is a highly select cohort. There's a lot of caveats to this. And obviously, this test is not ready for prime time, but really highlights what we need in urothelial cancer. So, John, your group's done a ton of work in upper tract urothelial cancer, genomics and genetics. What's your take on this test? Are we looking at the right methylation markers here? Is this a step in the right direction?
I think just to echo some of Sarah's points, and that is that we need a better and non-invasive means to sort out what's going on in patients with upper tract disease. And there are a ton of biomarkers we can look at. There are genomic markers, there's cell-free DNA markers, there's and there's a lot of groups that are doing this type of work right now. Some of the challenges come from, as you pointed out, what to do in the setting of low-grade disease. What's the yield of what we're seeing in the upper tract? What do you do with somebody who's got obstruction in the upper tract, hydronephrosis? Or how do these tests perform in situations where, say, you've got a diversion, ileal conduit or neobladder? Are you going to have problems where you're going to lose signal as a result of that, or you're going to get some other types of some other signal that's coming out of the bowels? So I think there are great challenges, but also great needs, as you were mentioning, Phil. So this study is very interesting. They looked at, this is a commercial test that's out there, that's available, that's being developed specifically for looking at urothelial carcinoma. And they've done studies like this already in bladder and sort of done some validation work there. And now they're looking for upper tract. I think what the interesting part is that some of this correlated with tumor volume in terms of what they saw. So there was sort of an association between the signal and how much volume of cancer was there. The hard part is trying to figure out how it helps us with some of the more refinements, such as stage. Stage is a big one for us, right? So we really need to know what's going on in the upper tract. Endoscopically, we have a very difficult time figuring out stage. With imaging, we have a very difficult time figuring out what's going on with stage. So anything that kind of gives us some more information about that aspect of care helps us, because we'll get into maybe some of this more later, but one big question we have in these patients is, what do we do about neoadjuvant? How do we pick the right patients for neoadjuvant therapies? And so anything that gives us more granularity in terms of helping us to understand what that risk looks like is really important. From the standpoint of finding cancer, yes or no? Is it there? This is interesting because it worked well in low grade and in high grade. So that's a good point. It doesn't necessarily distinguish between the two. So that's sort of one pitfall, I think, to some degree, but just the finding of cancer there. The things that I would have liked to have seen is in clinical use, they compared it to a group of normal controls, basically healthy controls, which usually that's your postdocs and your med students and other people walking around, or your colleagues and so forth. But in the real situation of what you're trying to figure that out in, it's going to be in patients with microhematuria, someone with kidney stones, somebody with active urinary tract infections. And that's where things are going to get a little complicated, because you're still going to see, and especially age match controls, right? Because these sounded like they were healthy young people. You get into a lot more when you're looking at DNA methylation markers. Think about what you're looking at. You're looking at some type of subtle transformation of a methylation marker in a gene. So methylation markers occur in patients who have a lot of oxidative damage in their genome. And so that can happen in older patients, smokers. That's sort of the group you want to look at as a control. So I think it's a great first effort, and it's really intriguing and interesting stuff. It's just, I think a slightly better control group would have been nice to look at. And I'm sure they'll do more work, because this is a great research group too. This is the team out of USC and others, and they'll figure it out, but it's a great first effort.
I'm really looking forward to seeing the next steps. I'm sure they're going to compare it with cytology, or at least, fold that arm in, larger groups, probably multi-institutional.
I do think it's interesting that they selected the patients that ultimately met their inclusion criteria. There was a lot of variability in there, which is kind of nice, because that's what you want to see, right? You want to see that it's not a super homogeneous, clean population that is going to be, quote unquote, maybe easier for the test to perform well. They did have a fair number of folks who, it was a small cohort, but 1 in 5 or so were low grade, which is not bad. And then they also had tumors that sort of span the staging, and they did have a couple that had variant histology as well, which obviously is a challenge. So I mean, I think that the comparison arm is actually really important. And obviously it's a small study with 50 tumors and 50 controls, but I think it's a good signal that we kind of need to follow. And again, as we sort of work to develop better diagnostic tests, having something that is non-invasive is definitely going to be helpful, because especially some of these tumors, obviously, especially when there's obstruction, it can be really hard to get up there. And so we need better tools. It's definitely, I think, an encouraging result as a first validation study.
Yeah, and it's going to be a perfect segue. Our next two articles are about the treatment of upper tract urothelial cancer. And before we know how to treat somebody, we have to accurately diagnose them, stage them, and according to the new guidelines, risk stratify them. So let's just talk about kind of diagnosis up front. Dr. Coleman, kind of, walk us through the basics of an upper tract urothelial cancer diagnosis. What should, the average patient comes in with suspicion of an upper tract cancer. How should we be working them up?
Yeah, that's a great question, Phil, and something that it's surprising how much variability there is out there when you start to look at how people evaluate these patients from the beginning. And there's a lot of questions that get raised, and the scenarios can be highly varied. But I think taking a standardized approach to these patients is something that, especially when we were putting the guidelines together, we really wanted to get across the idea that you really need to kind of have a standardized process when you're looking at a patient with suspected upper tract disease. I don't want to get into the whole history and physical stuff, because I know there's a whole part of Lynch syndrome that we peeled out, and that's I think a very important part of the guideline that people will appreciate and understand. But certainly, I think the original approach you have to have just from the beginning of your generic patient is, you need to do a proper endoscopic assessment. Let's just talk about the endoscopic and imaging side. So all patients really, as we know for hematuria guidelines, should get a proper cross-sectional imaging study of the upper tract. That includes typically a CT scan with contrast or an MRI with contrast, depending on their underlying kidney function, an endoscopic evaluation of the bladder with a cytology. And it's surprising how many people don't really collect cytologies at the time of routine cystoscopy, or at least beforehand, to get avoided cytology. But your yield will be higher with an instrumented cytology from the bladder. And that may even give you information that may be helpful later. Then for the upper tract, as far as doing endoscopic evaluation of upper tract cancers, a routine approach to upper tract should be for patients where you need information if information from the upper tract is going to help you in your decision-making process, and you need to learn more about what's going on there. In other words, if you're suspecting that you might do an endoscopic management for that patient, or you suspect that patient may benefit from, say, neoadjuvant chemotherapy, and you need a biopsy to show that it's high grade in order to offer that to them, then in patients who need endoscopic evaluation, endoscopy should be done gently. That means you have to go in carefully with either a flexible or semi-rigid scope. If you run into difficulty, you should really stop, put up a stent, what we do pre-stenting, we call it, to put a stent in up front, allow the ureter to dilate over 2 weeks, and then to come back and look again. But if you can do a gentle ureteroscopy to look up into the tract, and we differentiated between what we call the diagnostic ureteroscopy and therapeutic ureteroscopy. Diagnostic ureteroscopy meaning going in with the sole purpose of mapping out what's going on in the upper tract to gain information. So that is looking at things like tumor architecture, sites of tumor involvement, mapping out sites inside the upper tract. Is it in the ureter? What part of the ureter? Is it in the renal pelvis? Is it in the renal calyces? Is this multifocal cancer? Is it papillary? Is it sessile? You want to collect all that information in a very standardized fashion. And so we wrote that into the guidelines, and that is a standardized assessment endoscopically in terms of what data you should be collecting, because all that information can help you substratify your patients into different risk strata and help understand how better to manage them. So a unifocal tumor is going to be very different than a multifocal cancer, and even amongst high grade and low grade. Patients also should get a cytology from the upper tract as well as a biopsy. Cytology alone sometimes can help. If you get a cytology that comes back as high grade, that's high grade cancer, even in the setting of a low grade biopsy. Biopsies can be challenging in the upper tract, and it's not uncommon that people try and get biopsies and they're unsuccessful. So that's okay. Another important point was to try and do all of this before you do a retrograde, because retrograde contrast can cause some abnormalities in your cytology assessment. So Getting a retrograde study is certainly an important part of doing an endoscopic evaluation, but it can also confuse things sometimes when you're looking at the cytology samples.
Yeah, I think really important points. And, one of the things I love about this guideline is some of the new terminology it uses, right? Diagnostic versus therapeutic ureteroscopy. I think it makes it very clear for people what the intention of the procedure is. And listen, it wasn't that long ago. I mean, in my training, even a filling defect and an abnormal cytology, or maybe even not an abnormal cytology, led to a nephroureterectomy in the vast majority of patients, right? And so we've come a long way and understand that this disease is very heterogeneous, and getting as much information up front is really important to help making the right decision for these patients. So Sarah, if you wouldn't mind, take us through some of the practicalities of your diagnostic workup. What are some of the things you think about when you're working somebody up that may or may not be reflected in the guidelines?
Well, I think so. The first thing that is just really important, and this kind of goes back to how I approach everything in urothelial cancer, and all that we do. But obviously, having a practice, having a routine that you follow is really critical, because you don't want to skip steps. And I go back to some of the papers that have been written about how you do a high quality TURBT and the checklist, not only in terms of how you do the workup, but how you report it and document it so that you can go back to your notes and sort of get all of the necessary data, or somebody who's, if you're working with another provider and co-managing a patient, they get all the information that you've been able to capture to help appropriately risk stratify that patient. And this is, of course, really important, especially when we're working with our colleagues in medical oncology and thinking about whether or not we're going to think about neoadjuvant cytotoxic chemotherapy or any other sort of adjuvant treatments. So the things that I think about, so when you're looking at the tumor and describing it, I make sure, obviously, to document exact locations. I try to be really careful when I'm doing my upper tract endoscopy to sort of assess where I am with fluoro. So I make sure I'm in, lower third, middle third, upper third. That's going to change if you have to do any kind of extraoperative resection, that's going to change your options for reconstruction. So you really need to be sure. Are you in the middle third of the ureter? Are you below it or above it? Are you up by the calyces? And then I think being very, very complete. I do things like every time I go into a calyx, I do a quick fluoro just so I document that I've been into every single one of those calyces and I didn't miss a thing. And then when I document, the nature of each of the tumors, the sessile nature, papillary tumor, I try to use a reference standard for size. I think it's really hard to document the size of these tumors, as Dr. Coleman mentioned. It's hard on imaging. I can think of a patient I'm working on right now who, his imaging does not show a filling defect, but after the biopsy it did. The question is it bleeding and bruising and sort of old clot that's up there now, or is it the actual tumor? And I think it can be really, really tricky, because if the size is going to sort of drive you towards thinking about whether or not you can attempt an endoscopic therapeutic ureteroscopy, then you need to have accurately documented that. So you can use, whether it's a laser tip or your biopsy brush or something that how big it is, you can kind of put it up to the tumor and try to get as close to an accurate assessment of size as possible. Imaging wise, obviously making sure that there are good delays and you have a high quality delayed scan. I think, it's not uncommon that you might have a delayed scan that perhaps missed a significant part of the ureter because the delay wasn't quite long enough or it was too long. Obviously, peristalsis can change things. I look very closely at the actual nature of the ureter if I'm worried about a mid-ureteral tumor enhancement around the ureter, things like that. And then obviously, it's critical that we look at all of our own imaging in terms of assessing potential regional adenopathy, the character of the regional adenopathy, the number and sort of, prominence and size measures of the lymph nodes. And then, of course, upper, chest staging and making sure that you've completed the metastatic assessment and know so that you've got a clear understanding of what's going on elsewhere. And then I will just make a plug for the fact that you also have to understand the patient and their priorities and their other sort of. We made several comments in the guidelines about the importance of really sort of understanding the comorbidity profile and sort of fitness for treatment or functional assessment of the patients in order to guide appropriate intensity of therapy. And because obviously we're going to risk stratify our therapy on the basis of the tumor risk characteristics, but also on sort of patient fitness for therapy.
Perfect. Sorry, you were just setting up the segues today. This is perfect. I'll just quickly say in my practice, the vast majority of patients, I tell them up front, we're doing kind of a diagnostic ureteroscopy. They're going to be in the operating room for less than an hour. Our goal is to get some tissue and figure out what they have, because depending on low grade, high grade, whatever factors we're going to get into in the next several minutes, really determines the next steps. And it's almost premature, I think, to subject somebody to a 2 or 3 hour ureteroscopy when they might have a high grade tumor that needs a nephroureterectomy anyway. That being said, this is the perfect segue into trying to figure out how we're going to treat these patients. And historically, we were all taught low grade cancers are non-invasive. High grade cancers, the vast majority of the time, are invasive and should be treated, therefore, as invasive or systemic disease. The NCCN breaks down risk stratification based solely on grade of tissue assessment. The EAU uses a low and high risk formula, which is not really clarified on whether that predicts stage or outcome or recurrence or whatever it may be. AUA is incredibly clear on their risk stratification in the guidelines. Dr. Coleman, why don't you just talk to us a little bit about the new risk stratification set forth by the AUA in the guidelines?
Yeah, I think getting at this issue of risk stratification is really important for all cancers, and we do it in urology routinely. We've done it for testis, we've done it for kidney, we do it for prostate, obviously, bladder. For upper tract, there have been some challenges, and we approach that, I think, through the guidelines in a very rigorous way. We went through and gathered a huge amount of data that was out in the published literature to look very closely at what would predict for the aspects of invasive high stage disease. And not surprisingly, the first breakdown comes from grade, and that's been a very well-known, very well-established criteria that predicts for more aggressive cancers. So essentially, the breakdown is into high two different categories of risk, high risk and low risk. And I think we successfully avoided sort of the lukewarm, middle ground of intermediate risk. We sort of said there is an intermediate risk category, but we can define that, I think, fairly clearly. So we came into essentially 4 categories. So there's high risk, low risk, which is defined as high grade, low grade, respectively. And then within those risk categories of high risk and low risk, we then defined categories of favorable and unfavorable. So let's start with low grade. So in the low grade, low risk category, low risk favorable cancers are those types of cancers that we would all recognize based on the natural history of this disease, what we know already, and what we see and what we've seen published. And that is unifocal cancers are favorable. Tumors that are papillary in their appearance are favorable. Tumors that when you do, or in a situation where you do your endoscopic evaluation and your cytology comes back as negative, meaning that there's no evidence of any high grade, and this is again according to Paris criteria. Maybe we didn't discuss that before, but the Paris criteria are used as the cytology grading criteria. So a negative cytology assessment. And also obstruction, so imaging features, as Sarah pointed out, and we included imaging features in the guidelines as far as clarifying for favorable risk. So no evidence of obstruction or invasion seen on imaging. And then in the low risk unfavorable category is all those things that I just mentioned, but the opposite. So if you have low grade cancer, but there's obstruction, and we've all seen low grade cancers that have obstructed ureters. That's usually a high volume or a large tumor, or a multifocal cancer that's low grade, that's present in the upper tract and in the ureter, and maybe even spreading into the bladder. Even though it's low risk, it's now considered unfavorable. On the high risk side, so the high grade cancers, the same rules apply. If you have a cytology which is positive in any patient, even with a low grade cancer that's biopsy proven low grade, but you have a positive high grade cytology, that automatically shifts you into the high risk category. That means that your biopsy may have been a good biopsy, but from sampling, targeting or sampling error, you may have missed the high grade component, that there's high grade cancer hiding there somewhere. You're just not seeing it. So, but unifocal high grade cancers are considered favorable. Tumors that are high grade papillary are considered favorable. and tumors that don't obstruct or show any evidence of invasion are considered favorable. And then the unfavorable ones exactly are the opposite, those that are invasive, those that have evidence of obstruction, those that are multifocal, those that are sessile in architecture, those all define the high risk unfavorable category. So I think if you go through the guidelines and the table and the guidelines that specifically lays that part out, it's pretty clear how to risk stratify patients. And those categories are also importantly attached to approaches to management, including defining a category of the low risk favorable group, which is amenable to endoscopic treatment. And then the high risk unfavorable or high risk favorable group that's amenable to chemotherapy options, neoadjuvant chemotherapy options. So I think all of that is sort of nicely tied. Those risk categories are nicely tied to management approaches.
I agree. I intuitively found this was very similar to my practice, and now find this a very easy way to describe to patients. And the way I think about this is that low risk favorable group, you are with nearly 100% certainty sure that this patient does not have a high grade or invasive tumor, and you lose very little by trying endoscopic approaches. Even if you think you can't manage it endoscopically, you lose very little by trying. That patient is not going to develop metastatic disease. You may subject them to another procedure or two, but you're not going to have an adverse oncologic outcome is the way I think about that group. Sarah, how do you think about that low risk group? And then we can kind of segue into the second article we want to talk about.
Yeah, no, I think our practices probably mirror each other pretty closely. Obviously, subjecting someone to a nephroureterectomy or even a distal ureterectomy and reimplant, those are substantially invasive procedures, to put it mildly, and especially in this oftentimes older patient population who have a high burden of things like renal dysfunction, baseline CKD. The decision to remove a kidney is a big deal. So if there are any options to safely, appropriately treat the cancer and in an organ sparing fashion, I think that's really critical. I think it's really challenging sometimes to be 100% sure that you're dealing with a completely low grade group, because as Jonathan mentioned, there's oftentimes some heterogeneity in the grade of these tumors, and that can be very challenging. So I try to make sure that I've done my very best to really be sure that I'm characterizing these patients appropriately. And also, when you have a larger tumor, especially, for example, up in the renal pelvis or in the calyces, that you can't necessarily stage, right? Our biopsy tools are so limited in their ability to actually assess for invasion, especially in the larger tumors, just because you're usually just looking at sort of a sea of papillary mass when you get up there. It can be very hard to try to even think about getting down to the base of it safely without causing a bleeding that then obscures your vision. I think that obviously it is helpful though to try to get at least enough of a sample to try to look for high grade disease if you can, because in those patients with those bulkier tumors in the upper tract, if you can assess for high grade disease, that's an important risk stratification parameter to then say, yes, this patient needs neoadjuvant chemotherapy before we take their kidney out. But obviously, trying to successfully endoscopically manage those patients who have low grade favorable risk disease, it's really, I think that's definitely the goal. And as you said, having this really kind of clear delineation of who that low risk group is really clearly, that helps us feel much more comfortable about trying to go back and not only maybe think about ablation. Obviously, we're going to talk about a couple of different options to try that, but ablate them and then get them onto a careful surveillance regimen. And that's the other thing that I think that the guidelines and the risk stratification framework really helps us with, is it gives us a clear way that we then can follow these patients after we've endoscopically managed them appropriately, so that we don't miss recurrences, because obviously one of the most challenging facets of this disease is its predisposition for recurrence.
So John, why don't we talk quickly about the mitomycin article? So UroGen 101 was, we'll call it a game changer, a couple of years ago when it was FDA approved for the ablative treatment of low-grade upper tract urothelial carcinoma. This paper specifically talks about this product being used for adjuvant treatment after resection. Just quickly tell us your thoughts on the difference of using this product for ablative therapy versus adjuvant therapy, and how this article fits in.
We've really been lacking for any types of good treatment modalities for upper tract urothelial carcinoma for a long time. We've been stuck with lasers. Trying to get drugs into the upper tract has been really challenging. So UroGen comes along with this phenomenal new agent, which is just for people out there who may not know about it. It's a thermo gel that you put in, so it's sensitive to temperature and does sort of the opposite of what you expect it to do, and that is that at cold temperatures it's a liquid, whereas at body temperature it's more like a jelly. So you can put a drug into this jelly, make it very cold, and inject it at a very cold temperature through a catheter or through a nephrostomy tube into the renal pelvis. And when it hits the normal renal pelvis and warms up to body temperature, it turns into a gel and it sits there, and it will slowly elute or dissolve over time. And then that drug washes around inside of the renal pelvis. And this company's decided to use mitomycin as the therapeutic agent because it's a well-known therapy that works for urothelial cancer, and especially for low-grade cancer. It really wasn't designed to treat high-grade cancer. It wasn't tested in high-grade, but in real-world use, people are apparently, and according to this article, are using it even for selected patients with high-grade. The original trial was done really in patients who had tumors that were 15 millimeters in size or smaller, and so they had to be measured carefully. And then you had to instill this drug and you put it in once a week for 6 weeks. And then they looked at the outcomes after the first round of therapy. And the outcomes were okay. In the patients who got a full course of therapy and then made it to the end of, say, a full year of follow-up, the overall outcome was around 40 to 50% efficacy in terms of what they saw. And there was some dropout of patients, so they lost patients along the way. So looking at the overall efficacy of the therapy, say 1 year later, while initially the outcomes were around 60% or 65% efficacy, with long-term follow-up, some patients got lost. But now the question in real-world use is, but how do we use this in combination with what we normally do, which is looking up into the kidney and actually getting out a laser, lasering away at whatever is there, trying to kill everything that we see, and then maybe using this as an adjuvant afterwards to mop up. So this is what this group or what this real-world experience kind of looked at. And they actually did stratify into those patients where they said if there was any evidence of residual cancer that was left over after the initial treatment, if it wasn't documented that all the tumor was treated, then, and there was definitely residual disease, sort of similar to what was done in the original trial, they called that the chemoablative group. And then in the patients who it was documented that full treatment was done so that all visible disease was destroyed, then they called that the adjuvant group. So they sort of split that down into two groups. And it was the numbers were sort of roughly similar between the two in terms of in both different arms. But there was 63 chemoablative cases. I'm sorry, there was 73 chemoablative patients and 59 adjuvant treated patients. So there was a slight difference between the two groups. But what they found is the patients who were treated adjuvantly had a better outcome than the patients who were treated with the chemoablative group. What I thought was interesting is that many of these patients had nephrostomy tubes placed, whereas in the original trial, at least the patients I put on trial, they were all treated with retrograde catheter placements, whereas here, roughly about 60% of the patients had nephrostomy tubes put in. So they were instilling through a nephrostomy tube, which I think is just a clinical practice that people have found expedient to be able to do this in the clinic, to put it in a nephrostomy tube and do it that way. But I think what this tells you is that in real world use, people are using this in a slightly different way to try and improve upon the outcomes that we're seeing in the clinical trial. It's encouraging that it can be used in this way. And the thing you'd worry about is toxicity, right? You're worried about systemic absorption, systemic toxicity if you're treating in the upper tract with a laser, and you're worried about little perforations and things that can occur. But it didn't seem like, at least, and this is a retrospective study. This isn't collected in sort of the rigorous way that a prospective trial would be collected. So they're not looking very closely at those types of complications. But at least it seems encouraging that patients could get this, and notably the efficacy rates were slightly higher. The downside. So if I was to say, well, what's going on here? Why am I, not really enthusiastic about it? I'd say, well, number one, you're still given 6 doses of this therapy. So it's 6 doses, and that's a lot. Patients, that I treated, and I still treat patients with this therapy, they're not really psyched about the 6 treatments. It's tough to get it in. There's still some scarring that goes on. There's still some problems with ureteral strictures that have kind of plagued this therapy. Not a huge amount. In fact, it actually looked pretty decent in this and looked better in this experience than it did in the actual original trial. So I think that's good. But then the other side you have to say is, these efficacy numbers are pretty close to what you get when you treat with just a laser. So how much actually added benefit did you really get from giving it as adjuvant? Because you can get pretty close to a 65, 60% success rate with a laser alone in low-grade upper tract disease when it's done in experienced hands. And that one last point is something I think I just wanted to make, and that is that when we're talking about endoscopic treatment for upper tract disease, an important point is that these are experienced doctors doing this, and this is something we stressed in the guidelines as well. And that is that this is a rare disease. There's only about 7,000 cases a year of upper tract urothelial carcinoma. And these are very vulnerable patients because they're many of them are bordering on kidney dysfunction. Some of them only have one kidney. And the margin for error can be very slim in some of these patients in terms of making mistakes. And one of the things I would just stress to people that are out there, and that is that if you have someone in your group, or somebody who's nearby who treats these patients regularly and routinely, you should make an effort to probably try and get these patients to the doctor who's got experience in treating them, because little mistakes in this disease can lead to big problems. That's just one caveat I would put out there that people should hopefully take home as a take-home point.
Yeah, I think it's a great point. Nobody's getting rich taking care of upper tract urothelial cancer. So this is one nobody should be embarrassed on referring out, or if they don't see it a lot. And I think we all experience that too. Sarah, what's your take on adjuvant Jelmyto? What's your practice with it right now? How are you using the UroGen product?
So I haven't actually used it as an adjuvant therapy yet. I think that this paper really made me think about that, and I'm intrigued. I do think that the additional treatments are challenging, and the question here is, what is the marginal additive benefit? I don't know that question has been fully answered. I think that the sort of response rates after complete versus, I think that in those patients you can't necessarily clear, you just try to think about, is this worth repeated laser treatments, or is it worth attempting some sort of adjuvant therapy based, if we sort of extrapolate from bladder, we certainly think about the data for the post-operative adjuvant intravesical therapy, and then thinking about obviously either in high risk disease, BCG, and in intermediate risk disease, intravesical chemo. So mechanistically, it makes sense that we should be trying to figure out a better way to deliver the drug to the upper tract. Attempting to assume that the reflux from the bladder through an indwelling stent is going to be sufficient, is going to allow for sufficient dwell. I think obviously this drug gives us a mechanism that is much more likely to get us that additional dwell time and contact time between the agent and the area that we're worried about. But I personally, I haven't used it in that way yet. I think that the challenges, I was worried about the stricture rates in the original trial. The stenosis rates in this trial were better. I wonder if that's because so many of these, instead of going and re-instrumenting the ureter each time, they were going from above with the percutaneous nephrostomy tubes. And I think that's a smart way to do it. I think it's probably going to be a lot easier for patients. Putting catheters up in clinic can certainly be done, but it's uncomfortable for a lot of patients, and some patients can't tolerate it. So, and I think the other tricky bit, I'm not sure all of your practices, I treat people from a long ways away. So the six visits in a row is tricky. When folks are flying from Alaska or coming across from Idaho or Montana to see us, we have to think about sort of the financial toxicity of all of that. And that does come into play here, making sure that you've got insurance coverage for this drug.
Yeah, absolutely.
So trying to balance all of those factors is critical.
Yeah, our current practice, and I think this is evolving. We're learning more about this drug and other products. But, our current practice, and I kind of use it as a surrogate. If you can endoscopically ablate somebody on one go, I don't really think about adjuvant products. But if you got to go to the operating room multiple times, even if you can clear them or not, it's probably worth a go with this UroGen product. And the way we do it, I actually prefer to give it retrograde. I think it's easier for the patients, but a lot of that is actually determined by their insurance, whether their insurance will cover the product in an ambulatory surgery center or in clinic. If it's only covered in clinic, they need a nephrostomy tube. If not, our preference is we do it in the ASC. The first one, we almost put everybody to sleep. So we learn their urinary tract and what it's going to be like and make sure we're giving the right amount of product. And then if it's relatively straightforward and they tolerate it, we'll try to give the other injections with them awake. And I learned that on the trial, and the initial trial was that you can actually put a retrograde catheter up in most people if you're gentle with, and it's pretty well tolerated. They'll tell you when their pelvis is full of the product. And there's no doubt in my mind that this product works against low-grade upper tract urothelial cancer. It definitely kills upper tract urothelial cancer. And I think some of the stenosis is because it's effective. It's terribly caustic. It can create reactions in the upper tract, but it also kills cancer. So it's, I think, one of the areas where we can try and stay away from nephroureterectomies and segmental ureterectomies, with endoscopic approaches. So I think useful.
And I think it kind of levels the playing field a little bit, when it comes to that technical issue we talked about before, and that is it's probably a little bit more user-friendly for some people to say, look, I do retrogrades, I can probably get this gel up into somebody's kidney as well. I don't have to be a super skilled endoscopic, superstar like Phil Perazio or Sarah Sutka to do it. So, that I think that is something that kind of brings this kind of to the every man or every woman or every community place that they can do and probably get reasonably good results with.
Yeah. Mm-hmm. I just want to ask one other quick question about adjuvant therapies in low-grade disease, or we can even say high-grade disease. But what are we using in the bladder, and what do the guidelines say about treating the bladder, with upper tract urothelial cancer? Sarah, why don't you take us through some of your thoughts here and what the guidelines say?
Sure. So I think this is really important. This is, urothelial carcinoma is a pan-urothelial disease. It is a pan-urothelial vulnerability, and we have to be very aware of the risk of lower tract recurrence and obviously progression in patients who have upper tract disease. My practice has always been after treating the upper tract. I do usually use this, for example, like after nephroureterectomy on day 1 after surgery. As long as there's no significant JP output, all those patients get intravesical chemotherapy. I think that, and we've used gemcitabine preferentially. That's just what we're using at our institution now. I think it's a little bit easier to tolerate, and obviously the cost of it is favorable. And then all of these patients have to know that their bladders have to be surveilled in addition to their upper tract after treatment. And that's absolutely critical. So I think in the guidelines, we really looked at that data carefully and made recommendations about the importance regarding the importance of making sure that we're managing the bladder along with the upper tract, especially in patients in who we perform organ preserving disease or organ preserving management, but then also in those patients who do undergo ultimately a nephroureterectomy.
Yeah, and I think it's, this is one of the areas we do have level 1 evidence about bladder recurrence after nephroureterectomy, mm-hmm. and there's definite benefit to providing intravesical chemotherapy. I do it at the time of nephew. John, I'll ask you what your practice is in a second. I do it right in the operating room when we're doing the nephew at that time, and then the cystoscopy is less of a concern with the chemotherapy because we've already given it. But there's lots of ways to do that. And I think the retrospective data is growing, and the guidelines went through this at length, or at least the guidelines process that we all went through when we saw the evidence, that there's probably enough data to support at least a week recommendation for intravesical chemotherapy after ureteroscopy. And anytime I see a tumor, unless there's a contraindication, there's a problem with that patient's bladder, I tell them they're going to wake up with a catheter in and gemcitabine for an hour. And when a patient can't get gemcitabine, I'll put in a 3-way and just irrigate the best let them run CBI for an hour in the recovery room just to minimize the risk of implants, because we know that's a real phenomenon in upper tract disease. Dr. Coleman, any comments?
A couple quick ones. So I always make a case to the fellows, that unlike bladder, when we're doing bladder TUR and we can get an ELIC out, we can rinse out the bladder, we can really, decrease the amount of cellular stuff floating around in there at the end of a case, and it's nice and clean and it's all perfect, and we've done a good job with hemostasis and it looks fantastic. And the upper tract, it's like a snow globe up there. It is really tough to clear that out. For years, I've put up like double lumen catheters, and I just irrigate. And you want to do it very gently under very, very low pressure And the reason I use a double lumen is because that way I have one port that's open, and as I'm irrigating, I'm watching the other port. And as soon as I see any pressure coming out, I stop and I just very gently irrigate, to get everything out. But even that is a really bad way of doing it. So it's no surprise that bladder recurrences occur in those patients. I think from this, just from a practical perspective, how to do it. What I'll do is I do very similar to what you do, Phil. I put in a catheter. For us, it's a little bit challenging, just getting things to flow smoothly in the main OR or in PACU or in SDH, our outpatient surgical center, to get the drug there on time and everything. And sometimes there's just challenges. So just for flow reasons, I just put a 3-way in at the end of the case, and I leave one port clamped. And the reason I use a 3-way is because that way I don't have to undo the catheter in order to put the drug in, because we all worry about cauties and all kinds of stuff these days. So I use a 3-way with one port capped, and then I'll actually put a clamp, like a hemostat on the catheter, and send them down to the PACU that way. Then when they're awake, then I put it in the PACU while they're awake. That does two things for me. Number one is it allows me to know how they're feeling with the stuff in their bladder. So I'm not sending a fully anesthetized patient, down there with a bladder full of something that's maybe, agonizing for them. But then also, I can just do it at the bedside. I walk by on rounds. Hey, how you doing? I can talk to them about putting the drug in, and then we put it in, and then ask them to try and hold it in for an hour while they're cognizant and they're awake in terms of what's going on.
Yeah, great points. So the last article is your article, John, about TUCAD therapy, which is another ablative therapy, but this one has efficacy in high-grade disease. So let's talk about high risk and high-grade upper tract urothelial cancer. And let's go all the way to the far spectrum. Let's talk about the nasty diseases, the nastiest form of this disease. And let's just quickly go through guidelines. How should we be managing the high risk, unfavorable upper tract urothelial cancer? Dr. Succo, why don't you just tell us your thoughts on these patients and how you manage them?
This is a lethal disease if we don't manage it correctly, and if in disseminated disease, it's incurable. Right? This is analogous to that becomes analogous to node positive or metastatic bladder cancer, where there are very few options that get us to durable complete response. So you have to manage these patients very carefully. It's a multidisciplinary approach in my mind. We are not working in a vacuum here. We need to involve our colleagues from medical oncology early. I think that the POUT trial, which was a randomized controlled trial looking at adjuvant or neoadjuvant platinum-based chemotherapy prior to or after nephroureterectomy, it provides us with the level 1 evidence that there is a survival benefit when we engage our medical oncology colleagues and their expertise and get patients chemotherapy around the time of nephroureterectomy, with the objective of basically mopping up the micrometastatic disease. And so I talk to patients about the fact that this is something that's going to be multimodal therapy. I think that obviously with this kind of high-risk disease, endoscopic management is essentially off the table. If a patient is able to undergo extirpation by either distal ureterectomy for lower third ureter, and where you can reconstruct the ureter appropriately, have enough length to get the bladder up there off tension and do a reasonable repair, or if you're in for middle third, upper third, and then obviously renal pelvis disease, you're talking about a nephroureterectomy. The quality of that surgery matters. And there are a few key things that I think about when I'm talking to my residents and my fellows. The way that we handle the tissue is really important in those operations. There are a few things that I think make a huge difference, and we mentioned a lot of these in the guidelines. So one thing is getting distal control on the ureter at the time when you're going in to do the surgery. We just finished talking about the worries we have about basically seeding the lower tract or tumor spillage. And when you get into manipulating the kidney and the ureter to try to get all of that to do your dissection, I always worry about tumor cells basically just lavaging into the bladder. And so one of the first thing I do in any of those cases, if I'm doing it minimally invasively or open, is I put a big clip right below the ureter where I know we're in a safe realm if I can. In terms of the other surgical sort of key surgical steps, I think a lot about making sure, obviously, we're doing an oncologically safe operation. I do very strongly come down on how we handle the bladder cuff, making sure we do a proper bladder cuff excision. And now that can be done minimally invasively in appropriately experienced hands with a resection of the bladder cuff and then a cystography. And I think in the guidelines, we actually went through the data for the different ways that the bladder, that the ureteral orifice could be handled in terms of sort of the old pluck technique versus doing a formal resection. And the data supports doing an appropriate formal resection and making sure that we close the bladder. And so we went through in detail the rationale behind making that recommendation. And then the other part of it, of course, is doing an appropriate node dissection. So the data does support sort of thinking about regional node dissections. I think all of us may be a little bit varied, but I tend to extrapolate from the bladder data, and this is something I had done for a long time before this work that we did and reviewing all the literature extensively for the guidelines panel. But I essentially always remove the ipsilateral and intra-ureticaval nodes for upper tract. And then if the disease is in the lower ureter, they get a pelvic dissection as well, an anatomic appropriated template dissection, making sure that all of the regional lymph nodes are appropriately resected. And so those are kind of key surgical factors that I think about. The other thing, I think there's a lot of discussion right now about whether or not these should be handled in a minimally invasive fashion or through an open operation. Obviously, the open operation is more invasive, but I think you have to choose the operation that's appropriate to the patient and also your expertise. In small, if it's a bulky tumor and you have to do an extensive node dissection and you can do the appropriate templated node dissection through an open operation, then that's probably the correct oncologic procedure for that patient. There isn't data to support that one modality is superior to the other, but obviously experience and the ability to do the operation completely, whether it's a proper bladder cuff or the node dissection, that's really critical. And I think that those are things that I certainly talk to the patients about. You personalize the operative approach to the tumor and the patient and their surgical history and all of these other factors. But doing a high quality surgery is absolutely mandated.
Yeah, I think it's great to hear you say that, Sarah. And the way I think about the unfavorable high risk, I mean, this is systemic disease that is just not diagnosed yet. And chemotherapy and surgery it's not two different treatments. It's the same treatment, just like we talk about for bladder, right? Neoadjuvant chemotherapy for bladder cancer is not two different treatments. It's part of the same treatment paradigm. John, I was wondering how you kind of think about or rationalize, neoadjuvant versus adjuvant for your patients right now, and then we'll get into the last article.
So first of all, I think Sarah's point is that the POW trial has really established very clearly that adjuvant chemotherapy is beneficial in patients with upper tract urothelial carcinoma, especially in the appropriate selected setting, which is patients with T2 or greater disease. Patients who have node negative disease tend to do better than patients who have node positive disease. And the data also pretty clearly showed that patients who got cisplatin-based chemotherapy did better than patients who got carboplatin-based chemotherapy. And so if you take all that together, what that sort of leads you to is to say, well, to get cisplatin, you really need to have good kidney function. And so what do you do for the patient who's got a baseline GFR of 62 before you even take their kidney out? And yet that they've got, this is that bad disease, that unfavorable, high risk patient with clear evidence of invasive high-grade upper tract urothelial carcinoma that's invading into the renal pelvis and causing hydronephrosis. That patient's going to have bad disease, and that patient would benefit from adjuvant chemotherapy if they could get it. And the adjuvant chemotherapy that they should get is gemcitabine and cisplatin. But once you take that kidney out, that patient's not going to get cisplatin-based chemotherapy. They're going to get something else. Now, there are good alternatives to cisplatin-based chemotherapy now in the setting of IO-based therapy or checkpoint inhibitor therapy. There are, therapies out there that are probably going to be better than gem-carbo or any carbo-based regimen, but those trials haven't been done yet. So we can't say that there's level 1 evidence to support that. So, the best therapy we have right now is cisplatin-based chemotherapy for this disease. So giving it in the neoadjuvant setting really makes sense before you take that patient's kidney out. And now we've got data from 2 different prospective trials, phase 2 trials that were done, as well as evidence from several retrospective trials that are out there that clearly show that there are likely to be benefits, clinical benefits to patients who get neoadjuvant gemcitabine-based neoadjuvant cisplatin-based chemotherapy, even including a P0 rate, meaning no evidence of residual cancer in as many as 12 to 15% or 18% of those patients. So there can be real benefits in that setting. So I break it down based on GFR, Phil. That's basically what I do. So if a patient has a really good GFR up front, and their GFR is 90, I'm going to say, look, if I take that person's kidney out, they're going to have a GFR over 60, after surgery. And then we can figure out whether they need adjuvant chemotherapy and they'll benefit at that point. Problem is, there's not a lot of those patients out there, but there are a few. And so if they have good function, then they're fine. It's for the patients who have, a situation where you don't have good GFR up front, where you really have to start thinking about neoadjuvant chemotherapy in that patient population. So that's kind of how I break it down for my patients. And some of them get nervous and they say, well, I really want to get my kidney out. I want to get it out as soon as possible. And then I just sort of point out the data and say, well, look, we know that for patients who have high-grade upper tract urothelial carcinoma, their progression-free survival and overall survival rates can be as dismal as 50% over 5 years. And that's just by taking your kidney out today. And that's what you're going to see afterwards. So we have all kinds of new therapies and stuff that's out there, but none of it's proven to really improve upon what we can do with surgery.
Yeah. And I always remind them that the chemotherapy, this is an active agent. It's not waiting. You're not doing nothing. This is super active against this kind of cancer.
Oh, yeah. So
I want to get into our last article, and this gets into those nice, we're not even going to call them gray areas because we've now defined them in the guidelines. We have unfavorable low risk disease and favorable high risk disease, and we have a new ablative technology. So, John, this is your article. This was your group's work. Why don't you talk us, through this phase 1 trial and what this potentially means?
Yeah, so I think similar to everybody, we all have frustrations in trying to treat upper tract disease for patients with both low grade and high grade. And we all know that, lasers don't shoot around corners. And so how do you get around corners? How do you get into difficult spots inside the kidney and the renal pelvis when you're trying to treat this cancer? In looking out there in terms of what's available, and our lab's done studies. We even did some crazy studies at one point using spray cryotherapy. By the way, don't try it. It does terrible things to pig kidneys. It's a bad thing. But in looking at therapies that are out there, we were kind of interested in the photodynamic therapy world in terms of what's available. And there was a therapy called UTUC. That's a photodynamic agent that was developed by a plant scientist over in Israel. And it was kind of an interesting story. He developed it to treat his wife who had breast cancer. And so he was a plant scientist working in the lab, and all he knew was how plants worked. And he said, well, my wife has this really bad breast cancer. Is there anything I can do to come up with a cure to help her? And so he looked into the plant world to see what plants use, and they use a form of chlorophyll to fight off pathogens. And so he devised a form of chlorophyll in the lab that could be used. It was light activated with the idea of treating breast cancer. And slowly that therapy came into the clinic as a means of treating cancer. And a number of different cancers have been treated with this therapy. The reason why this particular form of photodynamic therapy is beneficial is because it has a very short half-life. Other photodynamic agents that are out there may last for days in your body. And so that means you're photosensitive. You can't really walk outside into the sunlight for sometimes a week or longer because you're photosensitive and routine sunlight can harm you. In this case, the therapy goes away within 6 hours. So you can leave fairly shortly after being treated. So we did a clinical trial trying to treat upper tract urothelial carcinoma. It was a phase 1 study. So we kind of took all comers of patients who were refusing nephroureterectomy for treatment of their cancer. And we used this as sort of a window of opportunity trial to say, let's treat these patients who are refusing nephro-U, and we'll try this and see if it works. And if it does work, then we'll continue them on therapy. And so we had a mixed bag of high grade and low grade cancers that we treated. It was an 18 patient study. We used a novel design called the CRM model, which is a Bayesian model to be able to do dose escalation, to go through the doses very quickly to get to the highest tolerated or the highest effective dose of light that we would use inside the kidney. And we found a fairly high degree of efficacy in this study. Well over 60% of patients showed response to therapy, including complete responders at a short term endpoint of 4 weeks after treatment. And it was a single treatment. It was a single time shot that we used. So it wasn't like some of the other therapies, which required multiple visits to be treated. So now that trial, based on these trial results, is now a multi-center trial that is being run at a number of different sites throughout the U.S. I think even, Sarah, you guys are running it there, the group down to, and now Vitaly Margulis is the PI for this study, the national PI for the trial down at UT Southwestern. So a lot of really good people involved in getting this therapy, giving it a good, careful look to see if it can help patients with upper tract disease.
What are some of your concerns about this therapy? What are some of the things that you worry about in either treating patients either with the drug or other issues?
So a big one's phototoxicity. You always worry about what may happen with light. And, my wife's an ophthalmologist. My dad was an ophthalmologist, completely unrelated, obviously, but I always worry about light toxicity to the eye. If the patient wakes up and a light shines in their eye, can it be damaged? Well, the good news is that there's never been any phototoxicity associated with this therapy. And this is the same type of drug that was actually used for a number of very large and well-publicized trials in prostate cancer, and they didn't show any phototoxicity in those trials either. So I think it's safe from that perspective. Part of the challenges here is getting the drug into patients. So it has to be mixed in the pharmacy, and then you have to bring it into the room and inject it into the patients. And so you got to try and keep it away from light exposure while you're doing that. So there are some challenges to getting the drug, into the patients, at your center. But those are the main issues I think that we've had. We really haven't had any major toxicities as far as treating patients. The number one toxicity in the trial was pain, flank pain, in these patients after treatment. And I think just from an issue of trial design, one of the mistakes that I made when I wrote the trial is I was worried about the issue of ureteral obstruction that may occur after standard ureteroscopy, because we all know that you can do ureteroscopy, go up with the scope and come out, and some patients may develop temporary obstruction as a result of just the procedure. So I said, let's just take that off the table and we'll just put stents in everybody. So everyone got a stent. That was mandated by the trial. And what we ended up finding is that a lot of patients had flank pain after the procedure. And that flank pain, we couldn't distinguish it between flank pain that was caused by the procedure or caused by the stents. So and it turned out that in these patients, we all took their stents out within a week, and a lot of the pain, the flank pain that patients were experiencing after the procedure went away as soon as we took the stents out. So that was sort of a confounder in our results to some degree.
Sarah, do you stent all your ureteroscopies, none of your ureteroscopies? What's your practice?
So it depends. A simple diagnostic ureteroscopy where we do minimal manipulation, I will sometimes try to avoid a stent. But I definitely, if I'm doing a lot of biopsying or any lasering, I do leave a stent, but I usually leave it on a dangler. And so with the string, and have the patients take it out a couple of days later, so they don't have to go through another cystoscopy to have it taken out. And also, if it's it's usually they're not going to be sort of waiting for a week or so to get back into the clinic. We're
John?
Really excited about getting this trial, the phase 3 trial, opened at UW. We're finally there. I think we're ready to start recruiting, which I'm excited for, and I think this is a great opportunity to sort of test a novel therapeutic that could potentially, again, offer us a lot more options for how we can endoscopically manage, especially those low risk. Like the phase 3 trial is for low grade disease. We're looking at those low grade favorable to patients, but trying to find ways to spare organs here, I think, is critical when we can.
Yeah, and it's really excited just to see trials and real research in upper tract disease being published. I mean, this is a disease that was orphaned in so many ways for so many years, and there's really interest and intrigue around it now. John, I'll ask you the same question to Sarah real quick. Stent or no stent? Pretty
much similar to what Sarah said. I will do retrograde at the end of the case. It depends on also about what I did. So if there's a lot of bleeding at the end of the case, or I sort of am a little worried because of I didn't get great hemostasis at the end, I'll leave a stent. But if it's a pretty simple procedure and the scope went up easily and I didn't have any problems, I always shoot a retrograde at the end just to make sure that the thing's open and it's draining well. And if it looks like it's draining beautifully and there's no problems, then I won't leave a stent. One last little thing I just want to comment on is I meant to make this point before, and that was just for the guidelines. The guideline is specifically for patients with localized upper tract cancer. So we were talking about before about patients with metastatic disease and so forth. That's a little outside of what the guideline covered. And so it's just important to keep that in mind when you guys are reading about the guideline later, and that this is specific to that patient population. But a whole nother ball of wax. And as you said, like, the great thing we need to do in this field now is put the science behind and the data behind the efforts that we're doing, and multi-center clinical trials. We've got great consortiums of people that are really interested in this disease now. And all of us just working together are going to move a lot faster than any one of us working alone. And the big field right now is going to be moving on to that field of what to do in the metastatic setting. That's a big challenge.
So I'll just make one quick comment, kind of in the the high risk ablative patient. Before we talked about low risk, and I said you lose very little or you lose nothing. I worry about the high risk patients. These are the patients we've seen progress. They don't want to have their kidney out. They've got a lot of reasons not to. So you ablate, endoscopic management. And then the next thing you know, they've got metastatic disease, sometimes without a big visible lesion in the kidney. So just a word of caution. We all worry about these patients. And that's why there's this favorable high risk category. And that, it's still cautioned to do ablative therapy in these patients. They really have to have a reason to have that kidney in if you're not going to treat them that way. So this
solitary kidney being a big one.
Yeah, solitary kidney being a huge one.
Yeah, and we're seeing more of those these days, right? That's a big part of the population that we deal with.
So this has been a tremendous conversation, and we set a huge bar for the rest of the podcast to follow. This has been a great conversation. We've covered Journal of Urology articles, we've covered guidelines, we've covered clinical management. I want to, just kind of give a quick plug for the guidelines again. It covers even more than we talked today. There's discussions of endoscopic tips and tricks that are pertinent to clinical practice, segmental ureterectomies in there, lymph node dissections. There are discussions of palliative treatment for patients who do have, kind of solitary kidneys or questionable indications for surgery. And there's a huge section about surveillance and how to follow these patients after you've done their definitive management, which I think once again will help us get to standardized treatments. So I will ask you both just to kind of, if you want to give us one quick plug for something in the guidelines we didn't cover, and then we'll sign off.
I think you just highlighted what I think is probably one of, beyond the risk stratification framework, I would say the most valuable part of the guidelines is the risk adapted surveillance suggestions and recommendations that we put forth. And it's not only based on the characteristics of the disease, but it's it's based on how we went through with the primary treatment. So among those patients, for example, with low risk, favorable disease who underwent a kidney or organ sparing approach, we talk about not only sort of the surveillance intervals for cystoscopy and watching the bladder, like we already talked about, but also thinking about how you surveil that upper tract, whether you do it with ureteroscopy or imaging. And then went through, of course, for kidney sparing high risk disease, and then after an ureterectomy. I really appreciated the opportunity to kind of delve into the literature behind sort of how we handle this disease. And there is the tricky thing here, we've mentioned it a few times, this is a rare entity, but it's a very, very heterogeneous, and it's very heterogeneous, which means that we need to kind of pool resources and pool forces here if we're going to kind of move the mark for our patients with upper tract urothelial carcinoma. And so again, having a standardized approach to not only how we diagnose it, how we work it up and characterize it, and then how we manage it is going to be critical. And then how we surveil these patients and sort of take them through survivorship. I think that's probably what I'm most excited about here. And thanks, Phil, for the opportunity to highlight this.
Yeah. And John, you were the chairman of the committee. Anything else you want to say about the guidelines that people need to know or about these articles? This is your opportunity.
Yeah. Well, first, I just want to say again, thanks, Phil, and thanks, Sarah, for talking together. It's always a pleasure to talk with you both, and thanks for the opportunity to kind of talk about this important topic. I want to let everyone know, the incredible amount of hard work that goes into this, and we kind of the people who went onto this panel, all of us on this call, and so many other people who aren't here today, but you'll know about them in the coming months. Spent a huge amount of time and effort trying to get this right. And I'm sure there are going to be, criticisms and things that are going to be leveled, and that's great because that will always make things better. When we're always interested in getting things better. But this was a really, I think, a very strong, solid effort, and everyone, put a ton of work into it. So I just want to thank them, and especially everyone from the AUA, and who put the the gas behind the engine on this stuff to make it all happen. So that was great. The one thing I think that's in the guidelines that we didn't go over and we mentioned earlier, that's Lynch syndrome. So I think it's really, really important for people to recognize that Lynch syndrome is part of this disease. And it goes unrecognized in the clinic all the time. I've picked up patients, everyone says, oh, it's only in young patients without a smoking history. Not true. I picked up 85-year-old patients with no family history whatsoever with Lynch syndrome for the first time, just because we did routine MMR testing, routine immunohistochemistry testing in those patients as part of our standard of care at our center. So I would say you need to ask the questions for your patients. You need to ask about their family histories, and most of them aren't going to get it right. They're going to not know that their Aunt Sally had gastric cancer. They're not going to know that, Uncle Bob had, colon cancer. They're just not going to get it. So, so asking those questions is important, but it's not always useful. It actually only captures about 30% of patients who have Lynch. So routine MMR testing, routine immunohistochemistry testing for upper tract cancers is universally embraced, or it's embraced as a universal testing modality for patients with upper tract cancers. So, and that's part of not only the AUA guidelines, it's part of the GYN guidelines for endometrial cancer and ovarian cancer. It's part of the GI surgeons guidelines for all gastric cancers. And even most colon cancers, is that patients get routine testing for MMR to look for Lynch. And it's now part of the AUA guidelines that all patients with upper tract urothelial carcinoma should be universally tested by some means. And we recommend MMR testing from IHC or MSI-high testing from IHC. If you have the ability to do genetic testing at your center, that's fine as well. We don't mandate exactly what test to do, but we do mandate universal testing for Lynch for patients with this disease, which is consistent with several other guidelines that are out there.
Wonderful, John. Important message for everybody to hear. So I want to take this opportunity last time to thank Dr. Sarah Suka and Dr. John Coleman for sharing their expertise and their time with us. Follow the Journal of Urology and all the other AUA publications, including Urology Practice Journal and JU Open Access on social media, Twitter, Facebook, Instagram pages. We really hope you enjoyed this and want to thank you for listening. So thanks again and have a wonderful day.